Welcome everyone, my name is Yi, and I'm your host for Occupational Medicine Pearls podcast. Today, we will be looking into a chemical that is involved with modern plastics. Yes, it is vinyl chloride, also known as vinyl chloride monomer, chloroethene or VCM. It is a colorless, highly flammable gas used almost exclusively to make polyvinyl chloride PVC. PVC is found everywhere. They are in the pipes, cable coatings, medical devices, flooring, and packaging. But here is the point. PVC itself is not the problem. The risk lies in the monomer during its production and the polymerization. The Australian WHS law, vinyl chloride is regarded as restricted carcinogen. So similar to other carcinogens, we can't use it without regulator authorization. As we already alluded to, exposure today is almost entirely confined to PVC manufacturing facilities, especially during polymerization, equipment cleaning, and maintenance. Before we look forward, we need to look back in the histories. In the 1960s and early 70s, workers in PVC plants across Europe and US began developing cancer so rare that we haven't seen in a normal population. They developed hepatic angiosarcoma. At that time, only about 25 cases had ever been described in the medical literature. Doctors and pathologists started noticing a pattern. These cases were not sporadic. They were clustering in vinyl chloride polymerization workers. By 1974, the link was undeniable, and the discovery became one of the landmark moments in occupational epidemiology. And it leads to the first recognition of vinyl chloride as a definitive human carcinogen, global regulatory changes, then it leads to development of restricted carcinogen lists and more introduction of stringent, more strict exposure standard and health monitoring programs. It is also one of the earliest examples of industry-wide synergistic risk recognition. Workers with hepatitis B or C or high alcohol intake had dramatically higher rates of hepatocellular carcinoma when exposed to vinyl chloride. So it is kind of a perfect storm of hepatic carcinogenesis, as you can say. After a brief flashback into history, we need to look at health monitoring and its component. When a worker is starting at the work exposed to vinyl chloride, we have to take their overall medical and occupational history, focusing on alcohol intake, history of viral hepatitis B and C, and related risk factors, history of hemochromatosis and other liver diseases, and history of smoking as well. If they had history of any of these conditions, or even acute hepatitis, and that they may not be suitable for the employment, and we should take serology for hepatitis B and C after counseling. Physical examination should also cover these medical history points as well. Vinyl chloride can irritate the respiratory tract. However, spirometry may not be needed routinely. After a worker started working in the exposure-prone work, they should undergo regular monitoring that include general physical health checkup and blood tests regularly. So that will include liver function tests, focusing on AST, ALT, GGT, ALP, and bilirubin, full blood count, especially MCV and platelet, reflecting the hepatocellular production side. They should be repeated annually. There is no specific biomarker for vinyl chloride-induced angiosarcoma or HCC in this instance. As we noted that these blood tests are monitoring for biological effect rather than biological marker, there is a promise of thiodiglycolic acid used as a biological marker, which is a metabolite of the vinyl chloride. However, at this stage, there is no biological exposure standard has been established. It's too early, probably. If we are looking at the workplace exposure, the current limit is 5 ppm, which will be changed next year. And if we are considering about removing someone from work, there should be symptoms related to vinyl chloride exposure, and there is effects on the biological monitoring before we will consider them. To understand vinyl chloride's toxic effects, we need to know its metabolism in human body. After inhalation, vinyl chloride is metabolized primarily in the liver by the usual cytochrome P450 2E1 enzyme pathway. The enzyme will convert vinyl chloride into chloroethylene oxide. That chemical is highly reactive and capable of binding to DNA, RNA, and proteins. Afterwards, chloroethylene oxide rearranges itself to chloroacetaldehyde. It is also reactive and forms DNA adducts. It can be involved in mutagenesis and carcinogenesis. So essentially, the enzyme cytochrome P450 2E1 turn the vinyl chloride into more dangerous metabolites in the liver. The liver had another process to detoxify them and conjugate them into glutathiones, but they can only do to a certain point. Their function will be certainly limited if there is concurrent infection like hepatitis B or C, or if the liver cells are damaged by alcohol or any other chemicals. So the question is, why angiosarcoma and not something other cancers? So the reactive metabolites preferentially damage sinusoidal endothelial cells lining the blood vessel. So damage is usually more confined to the blood vessels, and as a result is that these angiosarcomas are present in the liver. After this, we will go to clinical effects, usually as in acute and chronic. Once someone gets exposed to vinyl chloride, central nervous system is the primary target in the acute toxicity. It can depress the overall function of the CNS via a solvent effect. It likes to bind to lipid and protein components of the neural membrane, interrupting with the signal transmission. There may be a latent period of hours to days between exposure and symptom onset. So what sort of symptoms? Symptoms can include euphoria, dizziness, ataxia, drowsiness, headache, and loss of consciousness. At very high concentration, from 8,000 to 20,000 ppm, symptoms can escalate rapidly and death is possible. Respiratory irritation, wheezing, and chemical bronchitis can also happen. Perhaps that is also dangerous as well. And the vinyl chloride has the lowering effect on the heart muscles threshold for arrhythmia, so it can cause arrhythmia induced by other chemicals. On the skin, high dose exposure can cause frostbite-like injuries. This is with the acute high dose exposure. So if I have to summarize again, if someone is exposed to high dose gas of vinyl chloride, it can affect the central nervous system and respiratory system predominantly. After this, we look at long-term chronic exposure. Chronic exposure level at the occupational range has been associated with a range of symptoms, collectively termed vinyl chloride disease, that include Raynaud's syndrome, scleroderma, and acroosteolysis, which is bone reabsorption of terminal phalanges of the fingers. Think about when you cut the tip of your fingers and you only have the proximal and the middle segments. That's not very good. And it is one of those medical triads which are quite fancy to remember, but you may not find all of them at the same time. Things like peripheral neuropathy, cirrhosis, fibrosis, and portal hypertension, and the worst outcome, hepatic angiosarcoma and hepatocellular carcinoma. Hence, when we are monitoring biological effect, the regular checkup for liver function tests annually are essential. At the final component, we will look at the carcinogenicity of vinyl chloride. So vinyl chloride has been classified as category 1A carcinogen, and as we alluded before, as it can cause DNA and chromosomal damage. The evidence is strong. There is a large number of epidemiological studies and case reports that confirm the causative agent. There are also studies stating that it can increase the mortality related to brain cancer, lung, lymphatic, and hematopoietic systems. Other factors that can act in synergistic fashion with vinyl chloride include excessive alcohol consumption, and viral hepatitis. So that's all for vinyl chloride today. If I have to summarize, vinyl chloride is a colorless gas that are found in almost exclusively at PVC production. We use the biological monitoring annually to check the liver function and other health parameters to monitor its effect. In acute high-dose exposure, it is dangerous. Unfortunately, there is no specific biomarker for that. In the long run, it is associated with causing hepatic angiosarcoma. So that's it for today's episode of Occupational Medicine Pearls podcast. If you found this useful, please share it with your colleague and we will learn together. I'm Yi and I'll see you next time.